came early. I could show you a compelling video, 2.5 minutes. Will that be all right?
Yep.
So I'll share screen here.
My name is Ketty Adams, and
Pretty good.
I have
Good.
always had struggles with anything having to do with healthcare costs. As an adult, I've had to undergo a couple procedures and small surgeries that I've had to pay out of pocket for, aside from what my insurance would cover. But as many of us know, insurance doesn't cover everything, and it's been multiple paychecks that to cover any bills that I've had to pay for. And I wish that I could just willingly and easily go into the doctor for a procedure without having to pay thousands and thousands of dollars for just a small procedure. There's a constant concern about money, no matter what, regardless of health issues, and it causes a lot of stress and unable to enjoy life to the fullest. And I wish, not just for myself, but for others out there, that we could go and into the doctor and have a procedure done without having to pay thousands of dollars. I'd be more than willing to pay out my taxes or however that would be done. And there's with insurance, even there's co-insurance, and then there's a maximum out of pocket. So it's kind of deceiving when I go to the doctor what's actually going to be charged, because they might say, oh, it's this much money that your insurance will cover, and it does. I'll have that amount covered, but then there'll be an extra charge because of the maximum out of pocket. And in the past, that wasn't clear to me until I had a procedure done where I learned about that. And the maximum out of pocket is like a couple $1,000s more than the co-insurance. So it just gets super confusing. If I chose to have a kid, I believe even with my insurance, it would be about $7,000 to $10,000. And I've always wanted to have kids, but that's definitely a deterrent. I know in other countries, you can have a kid and you get time off of work and you don't have to pay $10,000 to have a kid, even with insurance. So I just enjoy being an aunt. And my sister has her kids, and hopefully one day maybe I will. Maybe I won't, but I know money is a big issue, and I don't want to spend all of my paycheck on medical stuff. That's mostly what I have to say about it. I know that I just wish it could be less expensive for everybody. That's my story.
So we're on a Matters How Doctors tour in 2009. We stopped in Bloomington, Indiana, and there was a woman in her mid-60s, and she said, I want grandchildren, but my kids are too afraid of cost, and I don't think they're going to have kids. So, Gail, should we?
Yeah, I think so.
Before I start?
Go for it. I've got it recording.
Okay, welcome everybody. Elizabeth, Brenda, John, Jim, Connie, and Lake Oswego, Anne, Patrick, Leslie, and Nancy, and Gail. Well, I think it's John.
Oh, I can fix that.
Yeah.
I would think so.
Yeah.
Yeah. So thanks for attending this knowledge camp. If you want to stop, just say, what about that slide? And we'll just get as far as you want to go and as quickly as you want to go. So I'm going to start the slides here. Well, greetings from Corvallis. Healthcare in our nation is in crisis, and Jesus calls us to the rescue. I'm Mike Huntington. I'm a retired physician here in Corvallis and chair of the UCC Central Pacific Conference Health Ministries Network. I worked for 35 years as a radiation oncologist and enjoyed my work. But the most distressing thing I noticed towards the end of my career was that patients were coming in with advanced cancers. And I didn't understand why. It just didn't make sense because we were getting better at diagnosing cancer. Well, what it turned out to be, as you might imagine, was that patients were so afraid of cost that they waited. They waited months, sometimes until a crisis would force them into the emergency room. And then, of course, we were way behind the 8 ball and try to catch up with their illness. It was very depressing, very sad to see. Then I learned that other countries, other developed countries, didn't let that happen to their people. You may have seen a sign like this at the doctor's office. We're sorry, your doctor's office is no longer able to accept the following types of insurance. So anybody have had that happen yet?
Mhm.
So you may be relieved to find out that your insurance is covered, but you may know somebody who's not been covered and they can't see their doctor. And so doctors, some of them stop seeing patients on Medicaid and Medicare or other insurances that are not in their network. And the real message is, it's not your fault, but this is goodbye. We found other patients whose insurance will pay us more. Well, what about workers who have negotiated relatively good commercial health plans? Now, notice I say commercial rather than private. Private sounds benign, commercial sounds commercial, and that's what it is. Workers like this who have worked hard to get their benefits may be reluctant to give that up for something called Medicare for All until something like this happens. The first thing that General Motors did after the United Auto Workers strike went on strike in 2019 was to cut off the workers' health insurance. So the phrase that if you like your health insurance, you can keep it rings pretty hollow. Today, we pay on the average $11,000 per person per year for healthcare, and this is an average. About half of us generate almost no cost in a given year because we aren't sick. Some will generate far more than 11,000 because of illness, and thousands of us will go bankrupt because of it. This is unsustainable. This is kind of a non-system. It impairs our freedom to feed ourselves, clothe ourselves, house ourselves, educate ourselves. Americans spend more for healthcare than the citizens of any other country. And it costs more, the increase in cost has been more than clothing, housing, and healthcare. You can see this kind of a climb and the red line there. That's just simply unsustainable. And if taken to its logical extreme, would mean we have no money for any of those other necessities for living. For a family of 4 receiving healthcare insurance through an employer, about one in every 3 or $4 is spent on healthcare. Notice the quotes, because that includes the cost of insurance. So the reason that the employer's contribution there you see in the middle is included as an employee's cost is that most of that money is foregone wages that's been lost in the negotiation process. And John Hawkins can comment on that later. A small portion, maybe was it 20%, is not taxed to the employer. So it's not quite that much, but it's a big, most of that money is foregone wages. And for the lowest 20% of income earners, that orange healthcare cost is about 1/3 of all of their family expenses. So the health of a nation can't be judged by its gross domestic product. In 2019, we found favorable economic indicators like gross domestic product, the stock market going up, annual rates of inflation and employment were improving. So unemployment, stocks, inflation, all looking good. But what was really happening on the ground? Other more important indicators were falling. 40% of Americans couldn't pay a surprise bill of $400. And many hospital, even routine hospital or doctor visits are more than that. Deaths of despair were at an all-time high. Those consists of suicide related to drug overdoses and other psychiatric problems. And untimely, the trust in institutions is at an all-time low. So our economy is not fundamentally dollars or numbers, it's value. Americans die because they can't afford healthcare. This scattergram of counties across the United States shows a direct relationship of mortality rates to unaffordability of care in each county. Not only do people die early because they can't afford healthcare, they also suffer physically because of untreated illness and emotionally under the stress of wondering how they get and afford the care they need. And we just saw the video about the young woman who has had that problem and wonders if she should or could ever have a baby because of cost. So 1/6 of our economy is healthcare related. And so what value are we getting for that big hunk of our economy? Well, not much. This graph shows life expectancy on the vertical column and expenditures on the horizontal column. And you can see the rapidly rising lines are countries that have a good life expectancy for less than half of what we're paying as you go along the bottom line of cost. So we're paying twice as much and we're getting very poor outcomes. And if you look at specific groups, African American males are at least 3 years, have 3 years lower life expectancy than other Americans. Well, how do we currently get our health care? Through an accident of history, that is wage controls during World War II, health insurance became tied to employment. About half of us still get our health insurance through our employer. Over the past 50 years, commercial health insurance has changed from an equitable and reasonable system to one in which clients are chosen based on profitability. They call it cherry picking and lemon dropping. As a result, the wealthy and the healthy have affordable health insurance and access to health care, but the unhealthy and the unwealthy tend not to. 1 in 3 Americans are unable to afford health care. We saw on the earlier slide what that means in terms of longevity. You probably know someone in that category, perhaps in your own family, who hasn't been able to afford the care they needed. A very small percentage of patients have what they call marketplace. That's individual policies, and it's very small amount. And these are policies purchased through the Affordable Care Act. And probably this is more now, maybe 10% are uninsured. And 40% are getting either Medicaid, Medicare, or care through the Indian Health Service. So why does it cost so much? Do we use more healthcare? Do we use more prescription drugs? Are our healthcare outcomes better? The answer to all 3 are no and no and no. So starting off, poor control of costs. This complex and confusing healthcare system that we have, even with the help of the Affordable Care Act, has not controlled the pricing of healthcare. The pricing makes it inaccessible. The defenders of private insurance imply that multiple insurers allow freedom of choice. In reality, there is little choice in commercial insurance because the employer may have only 1 or 2 plans to choose from, or none, And often those plans are restrictive in terms of doctors and services they can receive. Insurance companies determine what services are available. How much is covered, who you can see, and in the end, your costs. So the young lady at the start of our meeting said that in spite of being insured, her deductible, which she called out-of-pocket cap, and her copays are still going to be $7,000 to $10,000, even though she is, quote, insured. So this is the opposite of freedom. This is not, the freedom to choose an insurance company is not freedom to choose health or health care. This is unsustainable. So where does some of this cost come from? Well, just dealing with the complexity, excuse me, of our healthcare system has a tremendous cost. In the United States, there are between 1 and 2 billing clerks for every bed. Why is that so? And why does a hospital have a 25% administrative overhead in our country? Well, it's because there's hundreds of insurance companies, each with their own set of plans, and the patient has to know, and the hospital has to know whether they're in the right network. And sometimes they don't know, sometimes the providers don't know. And it takes a lot of administrative work to find out all of that. Then there's pre-authorizations, denials of care, a lot of administrative work. So that's why there's this difference between these two. So what about those billing clerks who are now paid to deny claims? Do you think maybe as a society we could train them to provide care? They can become nurses, doctors, medical assistants, technologists. Similar job transitions have occurred in many other fields. Over the past 100 years, blacksmiths and farriers became auto workers. There have been similar transitions in logging and mining industries. The CEOs of insurance companies are not evil. They're simply running a business. But I think we can agree that for population health, they're just in the wrong business. Health premiums provide over $600 million of royalties per year to AARP. They pay for logos for sports arenas. They cherry pick, they lemon drop. In other words, they select the healthy and wealthy and avoid the unhealthy and unwealthy. They collude with hospitals and the pharmaceutical industry to keep prices high as the market will bear in order to siphon off a hefty percentage of that price. All of this is good for business and logical for business, but bad for our health. Abraham Lincoln said that the legitimate object of government is to do for a community of people whatever they need to have done, or they cannot do it all so well for them or so well for themselves in their separate and individual capacities. So what are those services that we don't do so well on our own? Well, schools, fire protection, police protection, roads, clean water, parks, and dozens of other services that we either ask our government to provide or regulate, as in utilities, so that everybody can have access to the things they need to live. But there are other reasons that we can think about providing healthcare for everyone. Healing the sick was central to Jesus's ministry in the world, and his identity as the Messiah. His healing ministry was freely available to all. He did not ask for whether they were in the right network. His disciples were given the authority to heal the sick in his name. As Christians and UCC members, we are continually called to continue Jesus' ministry of healing the sick. Through our baptismal covenants, we are solemnly bound to seek and serve Christ in all people. Indeed, the United Church of Christ has long supported the concept of universal health care. In 2009, the General Synod adopted Resolution 13, an urgent call for advocacy and support of healthcare for all. At that time, the bill was HR 676, and that was reintroduced for 10 years. And the UCC in this resolution named that bill. So it was designed to cover all persons, present no financial barriers, provide comprehensive benefits, a choice of physicians and other health providers, and eliminating racial, ethnic, and other disparities. So how would we pay for this? Well, from what we've just talked about, we can see that we're paying twice as much as other countries for purposes that are not resulting in good health care. They are being paid to middlemen to administer the payments for health care. So instead of paying all of those out-of-pocket deductibles and premiums and copays, we would pay a tax. And most of the studies have shown that a single payer system would cost less than what we are now paying out of pocket and all the other costs of our current privatized system. Doctors would remain independent, and you may have heard some prominent physicians saying, well, this is just one step to socialism. I think we can say this is not socialized medicine, it's socially responsible medicine. So what can we do? Well, one of the presidential candidates said, I have a plan. And she didn't get very far with that. People don't want a plan. Martin Luther King said, I have a dream. What would that dream be for universal health care? I think it would be that every person gets the health care they need throughout life. Every person has living conditions that allow them to be healthy. No one goes bankrupt because of healthcare bills, and no one delays care because of cost. The biggest step towards fulfilling this dream in the last century was passage of Medicare and Medicaid, which made healthcare much more affordable and accessible for the elderly and those of low income. In this century, we've made some improvements with the Affordable Care Act, and that added millions of people to access to healthcare through Medicaid and Medicare, but it did nothing to control costs. It simply added more complexity, which adds more cost. So there is a House resolution called HR 1976. It's called the Medicare for All Act of 2021. And sorry. And it would take us to truly universal health care, sponsored by Representative Pramila Jayapal of Washington State. And if you want to get the details, just call me or let Gail know. I can get you the details of this bill. There's what if Congress and the current administration, or any administration, simply will not accept universal health care? Well, we can do maybe like our neighbors to the north did. They started province by province. So in the mid-50s, Tommy Douglas, who was a minister in Saskatchewan, proposed universal health care for the people of Saskatchewan. It got resistance from doctors both here and in Canada, but they got it through. And it became so popular that the other provinces wanted to do the same. So in the mid 70s, it became, or later it came national Medicare. They call it Medicare. And they've been very happy with it ever since. So these are the bills. Compared to private insurance, Medicare means stop wasting our money. This shows the 13 to 18% administrative overhead, and this is just in the companies themselves of dealing with health insurance. You can add another 15%, 10 to 15% on the side of the doctors and the hospitals having to manage all of this as well. Compared to the Medicare Parts A and B has a 2 to 3% administrative overhead. From 2008 to 2018, the growth in spending per enrollee under private insurance increased over 52%, while under Medicare, it was less than 22%. And this is with a population that tends to have more illness. So improved, expanded Medicare for all means fairness and freedom for all. I want you to take a look at this. Is probably the most instructive slide I have. We, a couple of years ago, compared ourselves to 16 other countries in terms of outcomes. We would want to be number one on this, of healthcare outcomes, longevity, maternal and infant mortality. We'd want to be the healthiest. But for all of our years up to age 65, we're at the bottom. Can you believe that? Wealthiest country in the world. We're at the bottom. But then here's a patriotism slide. I don't like to be criticizing the US. What happens at age 65? Anybody guess what happens? Finally, we get access to healthcare with far fewer financial barriers. So what can we do? Why should we limit this to a certain age group? And how do we put all this into plans of action? First of all, remember that dream. Every person gets the healthcare they need. Every person is allowed healthy living conditions. No one goes bankrupt because of healthcare bills. No one delays care because of cost. Make a plan. This is a crisis, no doubt about it. This is a crisis. We need to talk about it. We need to learn about it. So talk with the members of your church, hear their experiences. You'll probably hear stories like the young woman that you may have had a chance to hear at the start. Start your own universal healthcare ministry, as other UCC churches have done. Educate yourself. These are reliable sources. The Kaiser Family Foundation, it's not related directly to Kaiser Permanente. It's very balanced source of information. Commonwealth Fund is also very reliable. Physicians for National Health Program and Healthcare Now. The bottom two are more activists, so you might see more sort of promotion of universal healthcare in those two. The other thing you can do is find candidates who will support universal healthcare regardless of their political party. You can go to Ballotopedia and see how they voted to get an idea, or talk with them. You can recruit candidates. The Deb Patterson story is remarkable. As the members of Smyrna may recall, after the 2016 election, she said nothing to her husband or anyone else for 48 hours. And then on that third day, remembering, it makes me think of Easter somehow, she told her husband, I'm running for state senate. She had never run for office before, but she was very well qualified. And she did. And she ran against Jackie Winters, a popular senator for Marion County. She lost by about a 60-40 margin. And then she ran against the person who replaced Jackie and won by only 400 votes out of 70,000. She worked hard and she had support from a lot of people. So that's another way we can get closer. She's doing a wonderful job in the Senate right now. She's the chair of the Senate Senate Healthcare Committee. Please go to candidates' town halls and coffees. They're more approachable when they're candidates rather than after they're elected. Hold a coffee at your house for candidates. Provide candidates with stories like the one we saw at the start and data that they can use in their campaigns after they're elected. Tell your legislators what your family needs. And this includes our national US, our House and Senate. We're fortunate to have a representative and 2 senators that are fairly supportive. Senator Wyden needs a little work. You can find your legislators by just searching for Find My Legislator and say, I am your constituent. Please sponsor true universal health care that protects my family from healthcare related bankruptcy. But be sure and look up enough about them that you can thank them if they already support this. Get involved and find others, grassroots movement in your area. In our area, it's Mid-Valley Healthcare Advocates. For the state, it's Healthcare for All Oregon. And ask a member of that group to come speak at your church or at your home, whenever it's socially acceptable, or we don't have to socially distance anymore, but we're doing them online as well with Zooms. So have a living room conversation by Zoom. You can do it also with your congregation, the city council, get them to support the idea. When Corvallis, we got our school board to sign a resolution favoring universal health care. Healthcare for All Oregon is a statewide 501c3 not-for-profit organization. Has 130 member organizations and consists of unions, churches, civic groups, and other nonprofits and individuals. So how are we putting this dream into a plan in Oregon? As a result of the kind of activism we just talked about, the Oregon legislature passed a number of bills, has passed a number of bills over the past 30 years that have increased Oregonians' access to good health care. The most recent is Senate Bill 770, which passed in 2019. It created a 20-member task force to design a single payer or universal healthcare system for Oregon. Its principles are to secure healthcare as a fundamental element of a just society for all individuals, remove cost as a barrier to accessing healthcare, ensure access to services from birth to death, and based on evidence-informed decisions as determined by the Healthcare for All Oregon Board, which will be created. It won't provide everything that everybody wants. We couldn't afford that. But just like we did with the Oregon Health Plan, we may prioritize with the help of medical providers and the public how to decide what procedures we should pay for. The other principles involved are allowing access to any individual provider who is licensed. So this would not exclude chiropractors or naturopaths. As long as you are certified and registered, you would be included in the plan. It would allow access of healthcare resources according to need rather than where you happen to live or how much money you happen to have. So you can find this task force online, but these are the members. They're all highly regarded. They all, to get on this task force, they have had to say, yes, I am committed to universal health care. You may recognize some of you, Ed Junkins, who's one of the deans at the Lebanon Medical School and also city councilor here in Corvallis. So they're widely representing the state in diversity and geography. So they have met for the past year and a half, well, a little over a year, and have come up with a portion of a plan. They had a 6-month delay because of the pandemic, but their plan will be presented to the legislature in 2023. They'll still be working on it through January 2022. Actually, September 2022. So I want to remind us that we are in crisis in our healthcare. People are dying. 40,000 people die each year because they don't, in the country, they don't have access to healthcare. Our pastor Jen here in Corvallis last July reminded us that Jesus is in the other, the broken, the ill, the destitute. When we make sure everyone has access to health and healthcare, we remember Jesus. Remembering Jesus can give us the energy and desire to learn about the crisis in our healthcare system and take action. Questions?
Ann,
Is dental health included in the plan? Dental health?
Yes. Yes, it will be. And that requires us to demand it. There will be forces against all of this. And just as is happening in Congress right now, the current administration wants to include dental health, hearing, and vision. But that would have to be part of that 3.5 trillion bill. I think even Representative Pelosi and President Biden realize that they probably won't get that 3.5 trillion. So what will be given up? It could be dental care, unless we're mad enough to say include it, and then we're willing to pay for it in taxes.
I got a question, Mike. You said Senator Wyden needs a little work. What does that mean? Where does he need a little work?
Well, he's favored a lot of progressive things, and he put an important part into the Affordable Care Act that actually would allow states to create their own single payer system. But every time we go to a town hall, he says, I believe healthcare is a human right. And then maybe even in the same town hall, if somebody asks about universal healthcare, he'll say, well, one shoe doesn't fit all. What people need in Portland, Maine isn't the same as what people need in Portland, Oregon. And I did a little research on that meme, and it was a poll tested meme used by conservatives. Of course, one shoe fits all if you're talking about access to good health care. So that's his mood. And if you look up what he gets in contributions, you'll see a very large amount from insurance companies and pharmaceutical industry. So we need to take him to task, be courteous about it, but take him to task.
Jim Mankins put in a question in the chat. What should be done about all the people on Medicare Advantage?
Well, the Medicare Advantage plan is privatization of Medicare, and it's a dangerous trend for a number of reasons. The things that they tend to do once they get a hold of your Medicare plan, first of all, they have carefully selected you. They're not likely to market to you or get you on their plan if they think you are at high risk to cost them money. Then there's several things they do. They will, so what happens is they get a per capita payment of say $5,000 per year per member in their Medicare Advantage program. The lobbyists there in Congress lobby for that as high a reimbursement as they can, because their first, understandably, their first priority is to make sure they make a profit. The other thing they do is that they upcode. So let's say I go into the hospital with pneumonia, and they will simply find every other disease that could have been in my past history. And there's a whole industry designed to help you upcode that patient's diagnosis to gain more income. So that's another way in which Medicare Advantage is overpaid, and it's sucking out tremendous amounts of money from traditional Medicare. So what do we do about people who are already on it? Well, it's hard to say. If you have a good plan, say from OSU, and you're happy with it, it's an Medicare Advantage plan, to get off it. But here's the thing. What happens when people get really sick and need specialist care, they find that the Medicare Advantage plans have narrow networks and they aren't able to get the care they need. Often there's narrow formularies, for example, and so that the Medicare Advantage plan may not have the drug that you need. And so what ends up happening is that this person who's getting sicker can't get the care they need. So they just by default go back to traditional Medicare if they can get on. And the problem there is that once you come back from Medicare Advantage, you have to, you have pre-existing conditions. And so when you go for a supplemental Medigap plan, which is not Medicare Advantage, but covers that 20% that Medicare doesn't, then you may have to pay a very high premium for that. So it's, it's carefully crafted, all of this, by the insurance industry to make it hard to go back to traditional Medicare, but a lot of people have to because they can't get the care they need under Medicare Advantage.
Just raise your hand or just go ahead and unmute or put it in the chat. So Raylene says, do we know the tax amount
Oh,
that do we know the tax amount that other countries have that provide universal health care, and how it's determined, a percentage based on income or age? Just curious.
I'm not sure how other countries determine the amount of tax, but what I do know is that those people, the whole country in general, pays half of what we're paying. I'm sure it has to do with income tax. And so we would have to have an income tax or payroll tax or a combination of those to pay for such a system. And yet the studies, dozens of the studies can show that that amount that we would pay in taxes would be no more than, and probably less than, what we're paying now to insurance companies and their out-of-pocket costs as well.
Mhm. And Reverend John, is it Annie or Annie? Annie, okay. Says Wyden is important, but isn't House Rep Kurt Schrader causing more problems for healthcare reform right now? My question as well.
Definitely. Thank you, Reverend John. Representative Kurt Schrader sits on an important committee, and I think it's Commerce, that reviewed parts of this budget reconciliation bill that included the healthcare reforms that we're seeking. And Representative Schrader voted against the negotiation of price with the drug industry. And at least in his committee, that helped stop it. Well, there's a problem there. The savings from that ability to negotiate drug prices would be the money that would be needed to pay for all those other services that we're talking about, dental, hearing, and vision. Unfortunately, Representative Schrader gets a lot of money from the insurance and the pharmaceutical industry. So he needs attention as well. Gentle, no, maybe not gentle, courteous. And what works is stories. It helps to have the statistics. He needs that if he's going to be persuasive to his colleagues on those committees. But the stories, like the one you heard at the beginning, that really is helpful. Now there is one problem. This is Upton Sinclair who said, it's hard to make a man understand something if his salary depends on not understanding. So we're proposing to put a lot of people out of business. And we have to honor that. Like those clerks that I mentioned, and maybe the pharmaceutical sales reps and lots of other people. So if we're going to pass something like this, we have to have a strong transitional program that doesn't leave those people out to, hanging out to dry because we've taken away their industry.
I have a concern that I want to share. I'm always, I guess it, but quite, I don't know how to say this very well, but of course we're concerned not just with the welfare of Americans, right? As church, as people of God, we're concerned about all of the people of God. It seems like this effort has to somehow go alongside with a concern for worldwide healthcare. Are there efforts along those lines as well?
Well, separate from this movement, which is focused on the United States, this movement does think about other countries and is actually looks to them for guidance. But thinking of Africa and Middle East and countries that have very poor healthcare, yes, we need to reach out and help. And this may self-serving, but right now with the vaccines, should we be actually thinking about giving booster shots when, 90, I don't know what percentage now are we, 70% vaccinated? That's just Oregon maybe. But in Malawi, maybe it's 10%?
If that, yeah.
So
But tonight, the African continent is 6%.
Oh, is it 6%?
For the whole continent. Yeah.
So, that has to, you can look at this a very selfish way and say, this is a golden opportunity for medical diplomacy instead of our usual, military diplomacy, if you can call it that. And the drug industry, of course, is always a problem because, and the international trade agreements, because they don't want to give up their patents. They want to keep this, the much income as they can get from it. And I think that's a major block to the US doing what it should do, is provide vaccines for other countries rather than boosting the rest of us.
Well, I don't think the pandemic is going to end until we take care of the whole world. I mean, it's everybody.
Yeah,
It's just going to keep coming back around if we just take care of ourselves.
I agree with that one. And that message needs to be made more clearly. Thank you.
Jim has another question. Would Medicare for All negotiate for lower prescription costs? How would this reduction impact research?
Oh, good question. Yes, this is a central part of Medicare for All is to obtain negotiation of price with the drug industry. But we can do that, should do that even before we get Medicare for All. And that's in front of Congress right now, I mentioned earlier. And unfortunately, Representative Kurt Schrader blocked it out of one committee. And the favorite response from the drug industry is that, oh, our prices have to be high in this country because the rest of the world keeps their prices low, depending on us to do our research. Well, that is bullshit. Their research is mainly to keep their patents green. And most of the research for breakthrough drugs has been done by you and me with our taxes. So then once we find that drug, we turn it over to a drug company, and they do the job of making it, distributing it, which is an important job. But they can't claim that negotiating drug price will hamper their research.
I can comment on that a little bit. It was my industry. I left in the early 2000s, but I remember I was in research, and when back then they could hardly market at all. You know, it was only in medical journals, and it was to physicians, and then since then this explosion of drug commercials all the time, every day, every channel. This would sort of stop some of that funding and have that be reallocated as well, right? Because that's got to be millions and millions of dollars that's spent on marketing.
Yeah.
And I remember our budget, the research budget was a good size, but the sales and marketing budget was a good size. So that was even 20 years ago. And the other thing was drug names. The names are different in the US than they are in other places, partly maybe culturally, but others, it was harder back then to compare the fact that this drug was the same in Canada as it was in the United States. And so you could charge way more for the one in the United States, but they had to negotiate in Canada. But it was a strategy to not call them the same thing, because then somebody could go, well, look what it cost. And, you'd have to do more digging to find out. And, so there's those strategies that have been out there for a long time. And I'm not that proud of my former industry.
Well, just to expand a little bit on that, most of the drug companies spend more on their marketing than they do on research. And then if you look inside the research, they have what they call their research budget. They spend a lot of money categorizing certain activities as research. In other words, if a nurse is involved in figuring out how to get a new way to market to nurses or physicians, that falls under research. So, or researching how to keep a patent alive by changing a molecule on the end of at the end of the drug, and then claiming it as a new drug, painting it purple and marketing the heck out of it. And then you can see, well, this drug is going to make my sex life better, and I'm going to live longer, and I'll have a happy family.
I have a question. When we're as consumers, I guess, choosing our health insurance companies, to the extent we have that choice. I mean, I do as a state employee. Does it make a difference which one we choose as far as moving universal health care in the right direction?
I'm not sure any of the companies would be the best company, the best performing and nicest company, the specific source. That's my faint sort of sense about things, but they all have to make a profit. And so, no, I don't think there's any way you can choose between them as being a little better or getting us closer to universal health care. They have to make a profit, and they won't be in the business if they can't.
Well, are there any nonprofit options?
Let's see, I think there might still be, but it doesn't make any difference. They have to behave, maybe Kaiser's nonprofit, but they have to behave like all the other businesses out there to survive, so that they do not become the repository for all the ones that everybody else doesn't want. I asked Patrick and John just to give a little bit of a insight from their backgrounds.
Well, Mike, I didn't want to take much time because you've covered it so well. I did want to just emphasize what you just sort of said, that healthcare is, there's the business of healthcare, and then there's the practice of healthcare. And I worked in for 37 years as a medical technologist in hospitals and outpatient labs. And so I was involved in the practice of healthcare. And the United States has very high quality. The practice of healthcare is good, but it's the business of healthcare that is where we're in trouble. And it's just as that young lady said at the very beginning, you should not be stressed, since stress is a cause of illness. You should not be stressed about your healthcare finances. In other words, our healthcare financial system is causing us illness. That is a bizarre situation. So I just emphasize there is the practice of healthcare and the business of healthcare. We have to fix the business of healthcare. And that's why the Healthcare for All Oregon has now pointed out in their definition of universal healthcare, they like to say it's publicly financed, but privately administered. And that's just a short thing to always keep in mind. It is publicly financed, but privately administered. That private administration, that is the quality practice of healthcare that we have now and that we will maintain. As a matter of fact, if you take the stress off of the healthcare system, off the healthcare workers to worry about finances, they would even do a better job at practicing healthcare. In hospitals, they have situations where if you have too many patients in the hospital that are non-insured or only partially insured, they can actually end up laying off workers even though the hospital's full, because their insurance mix is not good for their finances. So we need to separate the finances from the practice. That would be my bottom line. Thanks.
And I have been a union activist and member for 50 plus years. And when I was working for Lynn County for practically 20 years, I was always on the negotiation team for contracts. And always the biggest cost we had to negotiate was health insurance. And by the time I retired, the health insurance cost ate up almost all of the COLA that we could expect to get, the cost of living adjustment, and raises in terms of negotiating. I'm still active in SEIU retiree local, and the feedback we're getting from the current employees who are always, periodically in negotiations, is the tough one to negotiate is health insurance, and not have that eat up the entire increases that people are hoping to expect. And I remember we had a consultant with the union and the county negotiating. And in a meeting with the executive folks, he was saying, and this would have been, probably 2003, that he expected within about 30 years, so 2035, thereabouts, that what we would negotiate in terms of health insurance would eat up all of any potential COLA, and eventually even starting eating into maybe more and more cost to the employee. So all I can say is that it's an unsustainable practice. And the rest of the world has figured that out. Our problem is we've had a private insurance companies for so long. They have a whole lot of power and influence. And we're just going to have to rise up as individuals and work with our political leaders to say this is unsustainable, and we need to have universal health care. And that's basically all I have to say.
Thanks, John.
I don't have a question, but I just want to say that I have a daughter who lives in Finland. She is married to a Finn, and she has retained her U.S. citizenship so far. I keep asking her, why are you doing that, frankly? But she has excellent health care through the Finnish healthcare system, even though she is an American. I'm very much a socialist at this point in my life.
Yeah, thank you, Connie. And somehow they're managed to do that, to even take care of non-citizens. There must be some kind of restriction, but that's why our current bills are to provide care for all US residents. It does not say citizens.
Raylene put in the chat, the union issues seem to fall in line with how Medicare and Social Security adjusts. Our increase in pay via Social Security seldom matches the increase in Medicare costs, so there really is no raise or pay increase.
Yeah, workers' take-home pay, maybe John can correct me on this, has essentially not changed for 20 years.
Mm-hmm.
Is that close?
Close.
I was going to add in my sister was in Italy a few years ago with a group of about 4 or 5 folks from Southern California, and one of them had to be hospitalized, spent 4 days in the hospital and got a bill for $15.
Yeah, some places don't know what to do. They've never had to bill anybody. They're like in England.
Yeah.
And Leslie says, my parents in Seattle used to go to Canada to buy their medicines. It's crazy. This is so much craziness in the system.
If we were able to negotiate price as the VA system does, we'd save 40% of our costs, which could pay for a lot of other healthcare. So I'm thinking of Lake Oswego and anyone in Schrader's district, especially as a member of a church member, it's pretty awkward to say anything that's really political. But if it's just focused on, let's make sure our elected representatives pushing for healthcare, negotiate drug price, whatever it is. Yeah.
Yeah, I'm on it. I'm on him.
Okay.
I don't have any problem being political. It's not easy to Jesus. So
yeah, that's right.
Yeah.
One of our infamous shirts from Clackamas UCC says the gospel is anti-fascist.
Yeah.
So, Jesus was an activist, and we're called to be too.
Yeah.
Would it be fair to tell him that if he doesn't support it, he'll go to hell? Oh, wrong denomination.
I'll try any tactic at this point.
John grew up in a very conservative church.
Can we threaten to make it hell for him here? Yeah.
Can we do what, Raylene?
Right. Can we threaten him to make it hell for him here?
Oh,
Yeah.
Yeah, well, our member of our little healthcare group down here has talked with Representative Schrader and his legislative assistants. And it looks like Representative Schrader is doing exactly what he has to do to stay in office because of the balance. And so it's, I suppose, more of a matter of educating all the people in his district, no matter how red or blue they are, that this demand for a better healthcare system outweighs any other political force.
Yeah, I'm losing patience with people who are more worried about the balance and about getting reelected than they are about public policy. I mean, what's the point? If we can't even agree that we should have, strong voting rights, then what's the point?
Yeah.
Well, and part of his formula doesn't have anything to do with people in the district. It has to do with where he's getting his campaign money from too.
Oh,
Yeah.
okay. Yeah, it's hard to influence CEO of a drug company, but in the end result, they don't own the vote, so they can pour a lot of money in, but they can't vote. So we just try to persuade as many people, or educate, I guess, inform. Then the important thing is to listen first, because I've asked people about this. They say it's socialized medicine. And then you have to find out what they mean by that. And if you talk long enough with them, you might find out that his wife, this is a man I met in Lebanon, he was in his early 80s and getting care through the VA and Medicare. And he did not want socialized medicine. But his wife, who was younger than retirement age, had diabetes and just couldn't find doctors and couldn't get her health, care as she needed. And I missed an opportunity there to talk more about the VA and how that is a government program and the Medicare is. And, you just I didn't listen well. But first you have to find out why they're so concerned about it. Nancy and Pat, you haven't jumped in for a while.
Well, I was just thinking as we were talking, I have a person at my office who has family in Denmark, and she just visited her family a few weeks back. And of course, Denmark is doing amazingly well with the pandemic right now. They've had some rough times, but they have very, very good cooperation with vaccination in that country and masking rules when they needed them and things like that. And it's pretty much back to life as usual there, according to what she experienced. And that, of course, is an example of a country that is taking care of all of their citizens. Please correct me if I'm wrong, but I believe they've done that for quite some time. And the trust in that system is clearly very high, and it has benefited everyone in that nation. And I look at what we have, where there's so much mistrust and so much misinformation, and people not understanding what's in their best interest or someone else's, or not being able to sort out what is rhetoric and what is misinformation from what is helpful and useful and authoritative. And I can't help but think that part of our problem is this kind of war that's going on between the priorities of health care and the priorities of the health, insurance complex, pharma, et cetera, the business priority versus the care priority. And, we've created so much noise that people don't know what to think.
I agree. I think it is person-to-person conversation, a lot of it. it has to take place so you can find out why they're so distrustful of government, and maybe for completely different reasons than you thought. I mean, after the Oregon, what did they call it? The sign-up system for the Oregon Health Plan electronic system kind of tanked. That didn't make people very confident in government. But there may be other reasons that you can talk about, and then finally get back to the point where government is us. We probably do have to go to Salem. We probably do have to talk with our candidates and our elected officials in order for this to change. And it's a long process, but I think that's our answer to the distrust. Are they going to be able to trust the CEO of an insurance company, or even find out who it is compared to your representative?
One of the arguments that I've heard for universal health care for all is that our country is too big to manage that kind of system. What is a good response to reiterate with those people?
Yeah, well, that could have several tones to it, like the diversity of people of color. Will we ever be able to talk with each other? And maybe that's a vote for doing it like Canada did. They did province by province. We could do state by state, where people can at least talk with each other a little more and have a closer relationship with their elected representatives. But Brazil, not much smaller than the US, has done it. They call it a public healthcare system. No one goes bankrupt because they don't have insurance. The public plan is not something a wealthy person would want to get treated in if they can afford something more, but at least they're taking care of everybody. So I would say that's not a sound argument that we're too big or too diverse.
Some political campaigns for various issues have focused some attention on who's getting rich from this. So who is getting rich? It's the CEOs of the healthcare companies and their investors and pharma, right?
Yeah, well, the CEO salaries are kind of catch your attention, $35 million or whatever a year for some of them. But that total amount is minuscule compared to the overall amount that we pay more than other countries. It's just a symptom. And the same disparity in CEO to floor worker is true in other industries as well. The biggest cost is related to the complexity and confusion that our system has. I don't know if I got close to your question. Oh yeah, who else is making money? Well, obviously the pharmaceutical industry and this whole industry that is devoted to help the providers navigate our Byzantine system. That's a very expensive and a very lucrative industry. So they're making a lot of money. Doctors make a lot of money. Should an orthopedist coming straight out of it residency expect to get $500,000 a year? Or should any physician expect to get $1 million a year? Well, they have to pay off their medical debt, right? Well, how many years does it take at $500,000 a year to pay that off? But we really need
a lot if you're buying homes and boats and fancy cars and taking trips and building fancy offices.
Yep. And there's that competition too. Well, that dermatologist makes more than I do, and it's not fair. So what we really need to emphasize is primary care. And it's not that primary care doctors are underpaid compared to other countries. Probably they're a little bit about the same as in Canada. It's just that when medical students come out of training, they're looking for the fastest way to pay off their medical debt. And so you might specialize to accomplish that. But, well, go ahead. I'm sorry, Jim.
Finish what you're saying. Yes.
Oh, just that I think we need to elevate the status of primary care to where it should be, which is the most important part of healthcare delivery. Somebody who knows you, somebody you can trust, somebody who can explain why you should get that vaccination or stop smoking or take care of your diabetes. We don't have that strong primary care force, and as a result, we end up with people on dialysis because they don't know how to take care of their diabetes, or they end up losing legs or their lives. So that's the other part, is we need to elevate primary care. I'm sorry, Jim, go ahead.
I was just had two things, but one was when we visited Denmark and Germany, people we talked to said, yes, we pay quite a bit more taxes than you do. You pay maybe 25, 30%, and we pay quite a bit more than that. But when you take what you're paying for your premiums and all that and put it in the pile, they're just about even, or maybe even we're doing a little bit better than you.
Yeah.
Since we have no worries about bankruptcy, we have no worry that our grandparents and our wives and our children will be taken care of. Yep. That worry just is wonderful for us. Yep. They talked to one man on the news, and he was one of those anarchists, white, fascist in Germany. And they said, I suppose you're really against government controlling. Oh, yes, really much. And you wouldn't want your health care. He goes, are you nuts? Of course I want my health care. Very important to me. I think we need to remember that when we face people that are so anti this, anti that, that probably their desires for healthcare are very similar to ours. Yeah. And if we fight among ourselves, the people raking in the money are just going to laugh and think that's great. Yeah. We need to work together. Yeah. Care about each other, even if we can't agree on this stupid stuff they think. We can agree on our kids and our family having healthcare. Yeah. Yeah.
Jim, I had a friend who was listening to a group of 5 people rail against socialism and how we were going socialist, and all 5 of them were on Medicare.
Hey, Raylene, you had a question?
Yeah, I was just going to say we've politicized so much of our services. It should never have been a political issue to decide if you're going to get a vaccination. Or if you're going to wear a mask. It should never be a political decision if we're going to have good health care. And so it's like the Reds and the Blues are going to fight against each other, especially in today's environment, where if anything, the Democrats are going to bring up, I'm one-sided because I'm a Democrat, but if anything we bring up sounds good, it's too bad because the other side's going to say, well, as Democrats, we can't do it. We're not going to do it. We're going to fight them. Yep. And so, as long as we've politicized any of these social issues, social needs, we're shooting ourselves in the foot, Yeah.
So we've had a little success with our Republican Senator Boquist, who pretty far right, but several of us have gone up to talk with him, and his wife does the front office for him, was very receptive, and he did vote for this Senate bill, bill that created the task force. He was the only Republican to vote for it, and I want to imagine that it was because he was willing to listen to us, and we were willing to go there and talk with him. So.
Well, on the COVID picture, if you follow what's gone on in New Zealand and Oregon, their populations are pretty darn close. They're, and New Zealand is basically, they only shut down or go through major issues if there's a case or two reported, because they've had it under such good control. Where with us, we've had to get to the extreme in Oregon, and we've still got all these people balking at doing the basics.
Yeah.
They've maintained, I think where Oregon at one point, I'll pull a number out of the air, we had like 2,500 cases, they'd had 2, or
Wow.
they'd had 25, and we'd had 1,000. So it's like, we've got so many issues within our state, of one side fighting the other and not wanting to work together.
Yeah.
And so we just need to clean house. And
I had a friend from Army days who wanted to climb with me. He's out in California. I knew he was pretty conservative. And then the pandemic broke out, and I said, well, Mike, if you come up here, you'll have to wear a mask. The next email I got from him was, I'm out. I wouldn't have any fun. So that was too much of a political statement. I finally got him to come. The last objection was, I'm afraid that if I drive up to Oregon with my truck that has a Marines sticker on it, they'll trash my truck. And I said, Mike, the whole eastern 2/3 of the state is red. And he finally agreed to come up, and we had a nice hike. We were talking about religion. He wanted to convert me to his form of religion, and I wanted to convert him to my form of healthcare, and we're still speaking with each other.
Mike, John, Amy writes in the chat, kind of, it was right around when you were talking about primary care. I can tell you who is not getting rich: nurses, healthcare assistants, medication technicians, particularly in senior living centers. I was amazed to learn that they don't make much more than my kid working at Starbucks.
Yeah. So out of self-interest, I think we would want to make sure that we have a system that takes care of us when we are needing a nursing home, or even before that. And that may be part of a healthcare bill, or the human infrastructure that's part of the 3.5 trillion bill. I agree with you. We need to improve that, just out of self-interest, but out of fairness as well.
I'm curious, if I may ask a question. When you were speaking about the Healthcare for All Oregon initiative, you mentioned that all licensed healthcare providers would be included in that. Is that correct?
Yes.
Which is a great contrast with the Oregon Health Plan, of course, that does not include everyone. In my profession, I'm a psychologist. You had to be part of a local group of practitioners in order to be brought into the Oregon Health Plan when it was set up. And I tried to sign up, and I was told there were too many people in my area because I had the same phone exchange as Oregon City. And there was a group practice over there that were all therapists who had signed on. And I do assessment, I don't do therapy. So I'm a completely different type of practitioner, but I wasn't included. And so all of these years I've had to, when people call and say they're on the Oregon Health Plan, I've had to say, I'm so sorry, they will not pay me.
Yep.
And other than seeing them for free, that's the only thing that I could do, because that cut people out. And I'm pleased to know that this is going to be inclusive. So
yeah. That's the plan. And like every plan, there will be forces to chip away at least the funding. And it's going to take all of us. And it helps certainly to have Pastor Patterson, Reverend Patterson there, and others that we can talk with and go to the hearings and say, this is what it's like for me as a psychologist or other practitioner that's not an MD. And my patients need this, and don't take that out of there. And maybe through Gail, I can get this to you. There's a new threat to traditional Medicare that's coming up. It's related to Medicare Advantage. Nowadays, if you want to take Medicare Advantage, it's your choice. But there's a new program being tested by the Centers for Medicare, Medicaid, and it's called direct contracting entities. What these can do is they can take a whole metropolitan area or other region, and anyone who is on traditional Medicare will be enrolled in a Medicare Advantage-like program, with maybe without your knowledge, and certainly without your permission. So if I can get this information to you through Gail, or she can tell me how to do it, this would deserve your awareness. I've told Deb Patterson about it. She was not aware of it. It's a biggie, because this could basically commercialize all Medicare. So we need to stop it.
Is there a good website or something to go to about that, Mike? Or
not yet, but there's some very good talks about it that maybe we could distribute somehow, at least to the group here and maybe to others.
Yeah, we don't have contact information. I mean, if you would like to get something like that, if you just put, if you don't mind, put your email in the chat. You could do that.
Okay. So just to advertise a little bit here, John and Patrick and I will be happy to come to your church, either in person or by Zoom, to continue this discussion. We're happy to do it, and we've enjoyed, when we were able to travel before, we enjoyed visiting Medford and Smyrna and several, Hillsborough. I think a total of 8 churches that we visited. It's just fun to meet everybody and to share ideas.
Mike, I have a question, because recently I've seen, and maybe others have too, there's this sort of national campaign, or at least it comes on my TV, about negotiating Medicare, being able to negotiate healthcare costs. So you see these videos of people telling their stories and stuff like that. Is there anything like that for healthcare for all Oregon that would target the population in Oregon that's media related?
Well, there are stories like the one that I showed at the top that are on a webpage in Healthcare for Oregon. So I'll type that URL in there as well, hcao.org.
That's good.
And also ours here in Benton County, I'll put that one in too, MVHCA. And there we have stories like the one you heard at the beginning. We have them available, and several from college students and older people who've traveled and seen other countries' programs. So you're welcome to visit there also. Create, well, I think I mentioned it earlier, a healthcare ministry. We have one, we call it's what it's called, healthcare ministry, and mainly it's John and Patrick and me, but we get our heads together, once a month. And now we're also involving the Central Pacific Conference. It has now a department, a network. It's called a healthcare network in the Justice and Witness team. And so churches can do just the same thing. Several people, maybe it doesn't take more than 2 or 3, to be the sort of local educators and discussion builders And then we can share ideas amongst ourselves. So,
It might be helpful too to not just tell stories about people who have been hurt by the lack of healthcare, but people who benefited from progressive policies about healthcare. My brother, for example, was able to get drug treatment and continuing support, and now he's clean and sober and gainfully employed, and costing the system a whole lot less money than he was before. So
yeah. Yeah, those stories are important as well.